Maggie, are you back?
Yes, I am, Chair Foster.
Okay.
We're here, man, clean all the
See Member Holmes. Member Lunge, are you here?
I am.
Okay.
I'm here.
Walsh
Here.
and Merman.
Chair Foster, I believe
Yeah.
Dr. Merman will not be here this afternoon.
Okay.
Thank you.
All right. And then good afternoon, Bob. I see you here. How are you?
Afternoon, Chair Foster. I'm doing good. How about you?
I'm doing great. Nice to see you again. I had a great time at your community meeting. That was one of the really engaging ones. Thanks for doing that.
You. Thanks.
So we'll get going in a second. I'll call to order. I'll have our council swear you in, and if after council swears you in, if everyone could kind of go through and identify who's testifying and affirm the oath, and after that we'll just turn it to you.
Thank you.
Great. Okay. We'll resume the Green Mountain Care Board's hearing of August 30th and go back on the record. Sorry, let me do that again. Maggie, let's go back on the record.
We're back on the record.
And we'll resume the Green Mountain Care Board's hearing of August 30th. And we have the Porter Medical Center fiscal year 25 budget presentation. It is our last, but certainly not least, hearing that we have on hospital budgets. And I'll turn it to our council to swear in the witnesses, and then Mr. Ortmeyer and his team can present.
Thank you. Good afternoon. My name is Michael Barber, the board's general counsel. I'm going to see if I can do this a little more cleanly than last time. So I'm going to administer an oath to everyone who was presenting or maybe answering questions from the medical center or the network. And after I read the oath, if everyone could please state your name and then say "I do," that would be helpful for the record. So, do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
I do. I do.
I do.
I do.
I do.
I'm sorry, this is the court reporter. I need them to state their names because I don't see who's speaking.
Yeah, can we start again with you, Sunny, if you don't mind, and just after you say "I do," please state your name so it's clear for the record.
Yep. I do. Sunny Epen.
Thank you.
I do. Bob Wertmeyer.
I do. Scott Como.
I do. Jun Chan.
I do. Linda Havey.
I do. Brad DeCronf.
I do. Amy Vaughn.
I do. Kelly Champney.
I do. Rick Vincent. I do. Mark Stanislaus.
Okay, thank you. And if there is anyone who may be speaking later who was not sworn in, please speak up before you speak so we can take care of that. And with that, I'll turn it over to you to begin the presentation. Thank you.
Hey, Hillary, can you bring the presentation up? Great, thank you. Thank you, Chair Foster and members of the Green Mountain Care Board. Good afternoon and welcome to what I believe is your last hospital presentation. I'm Bob Wertmeyer, president of Porter Medical Center in Elizabethtown Community Hospital in New York. I've been with Porter now for 11 months and with the network for just a bit over 3 years, serving as president of Elizabethtown. Prior to coming here, I served in a variety of leadership roles for 30 years, at a health system in South Central Pennsylvania. Next slide. Just real briefly, a look at our agenda here for today. Next slide. Bit about Porter for everyone's awareness. Porter Hospital is part of Porter Medical Center, which also includes Helen Porter Rehab and Nursing. We're a 25-bed critical access hospital. Helen Porter, a 98-bed long-term care facility adjacent to us. We employ 708 total employees, 130 providers, and we have 192,000 patient encounters and just shy of 14,000 emergency room visits. Next slide. So here is just an overall listing of all of the different services that we provide here at Porter. Our goal is really keeping as much of this care in our local community as possible. As you can see, it's pretty much from birth through the end of life services, many of which of these service offerings are full-time. A few of them are offered several days per month with a physician visiting from UVMMC or another one of our partner hospitals. And I would like to note that during our Oliver Wyman review, as he looked at all of the different services that we do offer, all of these are appropriate to be done here, and nothing was on the at risk to stop services for any for not having enough cases. So we're very pleased that we'll be able to continue to provide these. Next slide. You can go forward. So I wanted to just talk briefly about what we've done a little bit in this current fiscal year, which is a lot of really good work here at Porter that sets the stage for our work in fiscal year 25. We had the opportunity this past September to try something a bit different in our approach to hospital operations, and being a part of the network allows us to share resources, as you know, across the network in areas like HR and IT and other back office functions. But we took it a step further and looked at how we can become more efficient with other hospitals, and specifically between Elizabethtown and Porter hospitals, both of which are critical access hospitals, similar services. And Porter does offer a little wider range with a surgical and birthing suite, along with a few additional specialists. The geography, as you can see on the map there, overlaps, and patients travel between both communities as well as staff. And I like to refer to this as really the southern region of our network. You see that the southern tip of this is in Ticonderoga, New York, which only has ambulatory services, and Porter is the closest inpatient hospital for that community. If that community of Ticonderoga chooses to go south for services, they go all the way 50 miles to Glens Falls. They can go to Plattsburgh, 90 miles, Burlington, 60 miles, and Porter is 30 miles from that location. So it makes sense to plan for care within this full community. It just obviously made sense to look at what could be done to cut down on any duplication that we have between our two institutions. And to that end, we had talked before about consolidating some roles. So my role as president, the chief medical officer, chief financial officer, the entire finance departments between the two hospitals have been consolidated. Our IT business partners, lab leadership, our philanthropy leadership, as well as some common corporate committees such as compliance and regulatory have also been consolidated for efficiencies. In this first year, we saved a combined $1.5 million through these efforts, and these savings are embedded in our budgets, and we'll continue to look at other areas that we can provide efficiencies. It's been a great year, as you can see here, from provider recruitment standpoint. Of all these providers, we have signed contracts. They're going to be starting within the next several weeks, which will be impacting our ability to provide greater access to care within the community. We use this year also to stabilize our finances at both Porter and Helen Porter. And Scott Como, our CFO, will go into that more in a little bit here. Other areas we focused on throughput for our patients by leveraging our network case management. This allows us to move patients and getting them to the right level of care in a more timely manner. We've also engaged in a very collaborative relationship with Addison County Home Health and Hospice, which gets patients who could be taken care of in their home setting engaged in these discussions upon entering the hospital. Work continues around our workforce initiatives to train and recruit staff as we share the same issues that all the Vermont hospitals have with the lack of available workforce. Slowly, we've been able to reduce our reliance on travelers, and that work continues. And I've already touched on our integration efforts, so I won't go into much more of that. And that always continues, remains an extremely valuable resource to the hospital here at Porter, because otherwise we wouldn't have the expertise or be able to afford what we do here in Addison County. Next slide. So this is a real familiar slide from the Oliver Wyman Group. This is a snapshot of the Middlebury community as it relates to the population. A real concerning trend for our population here. Overall population going down. The workforce, age of workforce is declining, the number in that age group, and the sharp increase in those going above 65, which further underscores our need for long-term care facilities and the need to be able to focus on areas, such as cardiology, stroke, and cancer care. Next slide. So all of this pre-work that we've done this year really brings us into our current year's budget, where we get to execute on all that planning to make a real difference in access and additional efficiencies in the way that we do our work. Our primary care offices, with all the work around panel sizes, recruitment, and scheduling simplification, as you've heard, has opened up access across our region. We have roughly around 2,100 new patient appointments available from a primary care perspective. And so far, since the beginning of August, since those panels have been opened, about 100 patients have scheduled into that access so far. There's other added benefits through our work also, in that patients will be able to schedule certain appointments online. MyChart is available to those who have signed up for it, which gives additional access to care. And all this work is even outside of our specialists that we have starting. Cardiology coming on board, orthopedics. Our orthopedic surgeon will also support the sports medicine department at Middlebury College. And from an OR perspective, we now have a network-wide view of our operating room capacity, and this helps guide patients to any capacity that we may have also here at Porter. The community health needs assessment this year is almost complete, but it's already identified the same high-risk areas for attention as this past year, which includes health access, which we're significantly addressing this year, as well as mental health and substance use, as well as housing. I mentioned our work already around the access, and we partner with the counseling services of Addison County for services in our ED, and we've inserted psychiatry into our primary care offices through our high-value care work. We continue to explore how we can support our local developers in the housing area, and this is beginning to take shape in the Virgins and Middlebury areas with affordable middle-income housing opportunities coming online early next year. This is vital to attracting and retaining our workforce to keep them living local here. Recognizing that we can't provide great care without great people, we continue to reinforce that our organization is a great place to work for both current and prospective employees. Our focus on our pipeline programs this year have been very productive. Just a couple examples around there. Our licensed nursing assistants, we had 11 employees come through the Patricia Hannaford Career Center. From an LPN perspective, 3 employees from Vermont Technical College. Really good success in our RN recruitment, 10 external hires plus 70 graduates. And we have 3 employees who have expressed interest in the Vermont State University RN program, which will begin next year. This all impacts our data, our traveler data. And at the start of the fiscal year, when you look at both Porter and Helen Porter, we had 76 travelers. And this is not just nursing, this is nursing and ancillary travelers, but our current traveler mix now is down to 66. So overall, it was a solid year supporting our vacancies and helping to reduce the reliance on travelers. Currently, we are engaged in a collective bargaining discussions with our support and technical staff. This represents about 30% of our staff that weren't unionized prior. The nursing staff currently is under a collective bargaining agreement. So in total now, this represents around 80% of our workforce, and we hope to have these negotiations completed by early September. Any opportunity we get, our teams will evaluate an opportunity to be more efficient from both the administrative aspect as well as sharing best practices among our 2 partner hospitals for improving care coordination or reducing variations in care. But we're also doing this while also taking advantage of having our larger network resources available for that same purpose. Protecting our staff and patients is of utmost importance, and additional security measures have been budgeted and have been put in place, such as increased security presence, additional lighting around campus, updated video equipment, de-escalation training, personal protective equipment, and the hiring of an emergency management coordinator to help manage when such events happen. The Epic EMR has been a game changer for us here in managing patient care. Whether it's managing local or for the purposes of care coordination to transferring to a higher level of care. Specialists can log into the patient chart for an e-consult, provide consultations to help with conditions not otherwise treated at Porter. And this practice of e-consults has doubled since last year to 305 e-consults so far year to date. Meeting the ongoing needs of our patients with the appropriate facilities is also an ongoing challenge, and we're in the midst of preparing a CON submission for a combined orthopedic and rehab practice to support this demand, as well as an appropriately sized emergency department. The current ED is severely undersized for the 13,750 patients that visit there annually. Our work in the post-acute area begins on day 1. Initiatives this year has been on case management and providing a dedicated utilization management resource for Porter, which facilitates patient placement at a more appropriate pace, allowing for increased swing admissions to help our partner hospitals with capacity. Also, our relationship with Addison County Home Health and Hospice is allowing for a pathway to hospice, as well as piloting a primary care program, allowing patients to remain at home for follow-up appointments, while the home health hospice nurses provides vital signs and helps the patient navigate the telehealth technology. And although Porter Nursing Facility is not part of the hospital review process formally, I would be remiss if I didn't mention its importance to the community as the sole long-term care facility in Addison County, which is financially supported by Porter Hospital. So from an overall programmatic standpoint, this is our work for the upcoming year. As noted in the narrative submitted, the budget does not contain any significant changes in volumes or services provided, but rather a new look at how we do things that drive efficiency through increased collaborations, resulting in increased access to care for the communities that we serve. So to discuss further the financial impact of all this work, I'll turn things over to Scott Como, our CFO.
Thank you, Bob. Good afternoon, everybody. Scott Como with the CFO for Porter Medical Center and also Elizabethtown Community Hospital. Before we jump into the numbers, I just want to say when constructing the Porter Hospital budget, as a UVM Health Network partner, we use common systems, there's common math, there's a lot of common calculations between some of the things that we do. I've specifically not included some of the slides that you've already seen, but I will reference where some of those calculations are the same. As a critical access hospital, we're quite different in the role that we play in the community and the network, and that you will see plays itself out in how we budget as well. Our cost coverage structure is different. We have a slightly smaller scope of services. So we're part of a larger network and taking advantage of the tools and resources we have available. But as you'll see in this budget, there's a very local slant to all that work. So if we can move forward to the next slide, Hillary. Thank you. So going into the year, it really started with right-sizing our expectations, starting with volumes. And as Bob alluded to, there are no big changes in our service mix plan for the upcoming year, but we did need to recalibrate because as with every year, we set a budget pretty far in advance and the actual results tend to wander from those intended budgets somewhat. So here's a summary of our FY25 budgeted volumes and how they compare with what was budgeted last year. In the case of admissions, we're really just the 22% change is just keeping pace with what we're seeing today. As being part of the network, we're getting much more savvy in bed placement and patient placement, and we are playing a larger role in that. And so we are seeing admissions tick up. So our budget is higher than last year's by about 22%. The OR volume budget seems about on par with last year, but really we are missing budget by about 10% at this point in FY24 due to surgeon vacancies. We do have signed contracts, as alluded to earlier, with providers who have been added to the budget. So we have budgeted OR case volumes back to what we are traditionally used to seeing. And the other thing of note are physician office visits. Bob mentioned some of the providers that are being added to the mix to bolster their services across various specialties at Porter. And the combined impact of those provider adds will be about a 13% increase in our physician office visits. And I would just say, these increases in volumes, specifically admissions and physician office visits, are one of the drivers that you see in our year-over-year net patient revenue increase, which I'll speak to a bit earlier. But these right sizing of our volume expectations are part of that. Next slide, Hillary. So after projecting our volumes where we think they will be, and we get into our conversation about rates. And as you've seen in the documents that we've submitted, we have a Medicare rate increase budgeted for Porter Hospital of 4%. We have a Medicaid increase of 0%, and we have a budgeted commercial rate increase of 2.9%. Our Medicare rate actually started higher than that. As a critical access hospital, that rate is tied to our allowable cost. And our cost report modeling suggested a Medicare rate slightly higher than that. But I would just like to mention the advent of Medicare Advantage plans are eroding the benefit of a critical access hospital status in that they rarely pay the equivalent of a Medicare rate. When we have a rate that we have settled with Medicare, we pass that rate sheet on to our Medicare Advantage plans. But because they operate more like commercial and traditional insurance plans, we rarely see that rate actualized. So we budgeted a blended rate there of 4%. And the commercial rate, I'm happy to report actually aligns with our hospital-based cost inflation assumptions. And the reason why we can bring those rates into alignment is because of our critical access hospital status and primarily that Medicare rate that you're not seeing at the other UVM partner hospitals. This adds up to a net patient revenue increase year over year of 4.2%. The chart at the bottom of the slide is similar to the chart you've seen with the medical center and CVMC, so I won't walk through it. But I think the takeaway here is that what is contributing to our 4.2% net patient revenue growth year over year is much more than rates, and primarily utilization based on the experience and what we expect to happen in 25. Next slide, Hillary. I just wanted to take one slide to acknowledge the FY23 net patient revenue budget enforcement letter that we received and responded to. I wanted to acknowledge that in this hearing. In FY23, Porter Hospital's net patient revenue was over budget by 10.5%. And again, and this seems to be the theme coming out of COVID, honestly, is that the volumes are starting to rematerialize and they're coming in different ways. I think during the time of COVID, we saw Medicaid and Medicare volumes really shrink as those populations' access to care, they just stopped coming in some regards. And now folks are coming back But then we have things layered on like Medicaid redetermination, so they're coming back in different ways. And so it's really been hard to track over the past 3 or 4 years. And I think we've seen that in all the hospital budgets. But in FY23, we saw a big bump in utilization, more than what we expected. And these rates, you can see here, these variances represent that. Pharmaceutical revenue has been mentioned as a driver of net patient revenue that year, which is true, but there was an offsetting cost associated with those pharmaceuticals that were ultimately included in patient care. And so for Porter Hospital, even though we had a 10.5% over budget result in net patient revenue, we only ended the year 0.2% above our budgeted margin, largely because of the offsetting cost incurred in providing this level of care. The patient days being so far over budget required inpatient nursing staff, primarily travelers at that time. And obviously that's a high cost item. Next slide, Hillary. This gets to the expense side of our budget. And overall, there's a budgeted 8% expense increase FY24 to 25, and we've broken that down between a 3% cost inflation driven increase and a 5% volume driven increase. And the 3% is detailed in the grid you can see on your slide. This is, again, similar to what we presented with the UVM Medical Center and CVMC presentations. On the right, you see a not all-inclusive listing of some of the resource additions that have come with that, or I would say that are associated with that volume-driven increase. Provider additions, as we've spoken to earlier, security, environmental services, education and employee wellness, RN, FTEs. There have been some offsetting FTE deductions from year-over-year budget to make room for these, but we wanted to highlight these investments specifically. Next slide, Hillary. So for Porter, what it comes down to is, balancing what's possible versus our financial health needs. Like every hospital, every organization, we need to be sustainable from a financial perspective, and that's always the goal. But as a critical access hospital, the levers that we have to pull to make that happen are a little limited. We have realities and what we can expect from volumes and services to offer. And we also know there are limits on the rates that we can charge. We understand the environment we're operating in. We are privileged to have the critical access hospital status and access to those rates. And we're happy that we can align our commercial ask to be directly in sync with what we can identify as inflation. All of this really produces a margin that allows our capital infrastructure investments. Bob touched on them briefly in his introduction. We have 2 CONs in the early planning stages, but we also have routine capital investments that are long overdue. Paving, sidewalks and parking lots, security cameras, equipment. There are a lot of things that are contingent on approval of this budget and the margin that it produces. And I would finish by acknowledging that the FY25 budgeted margin for Porter Hospital at 4.7%, I believe, is the highest of the 14 hospitals that you've reviewed. But as has been discussed many times, within the Porter Medical Center corporate structure, there's Porter Hospital, but there's also Helen Porter Nursing Home. And we do support Helen Porter Nursing Home to every extent that we can. And the budget we put together for Helen Porter has a negative operating margin of 32%, as you can see in the lower right corner. So our combined Porter Medical Center operating budget as it stands today is an operating margin of 1.9%. And that is all I had. Turn it back over to Bob.
Yeah, thank you, Scott. So in closing, Porter Hospital respectfully requests approval of the budget as submitted with a 2.99 commercial rate increase. 4.2% NPR increase, so that we're able to continue to provide local access to care, support our employees with competitive wages, and continue to invest in our facilities and infrastructure. So with that, I'll turn back over to you, Chair Foster.
All right, thank you very, very much. That was I'll open it up to the board members for any questions.
I'll go ahead and start. Good afternoon, everyone. So I wanted to start with some questions around your 24 projections. You're currently coming in, as you mentioned, under budget, and you attribute that to the vacancy in orthopedists. Could you speak to when the new providers will be starting? You mentioned you have contracts in place.
Sure. So the new orthopedic surgeon will be coming on board next month. Dr. Anderson has already been on site preparing for his arrival, working with our OR, getting everything ready so that he can hit the ground running. So he will actually be starting before the new fiscal year. Our cardiologist will be starting not long after that. I believe either the end of September or early October, cardiologist starts. Our primary care physician also starts the end of September. I think that covers the providers, if I'm not mistaken.
Thanks. So in response to staff questions, staff question number 7, and in your answer, it's page 3. You provided a chart with new staff and clinical positions in the 25 budget with the labor expenses. Would you be able to follow up with the impacts to net patient revenue from the new providers with more specificity? I wouldn't expect you to necessarily have that off the top of your head right now.
Yeah, member lunch for sure. They're baked into our budget at the individual provider level.
Okay. All right. Thank you. I'll formulate a follow-up question for that one. Give me one moment. I'm flipping through your narrative to find any to check my questions here to see if you answered them today. So in terms of the pharmaceutical expenses, which are a substantial increase, I believe your answer indicated that it was a combination of a different mix of drugs as well as price increases. Could you give us more detail about that, please?
I can share with you one anecdotal story that was given to me by our director of pharmacy when asking about this. And she had mentioned one particular patient who had come into the infusion service, and the particular drug that this person required was going to cost us $366,000 a year. And so this was just to treat a patient. And so for a budget the size of Porter Hospitals, that one patient was noticeable. And so that's the type of thing we're referencing. It's not just a cost that we incur to procure the drugs, but as patients present to us for different types of diagnoses, they require a different mix of drugs, and we're seeing a higher cost mix.
And is that largely connected, to the best of your knowledge, with cancer treatments?
We don't do chemo infusion at Porter Hospital, so I don't want to speak to what type of infusion it's for. Maybe
Okay.
Others can.
I'll pause in case others can.
This is Jun Chan, the interim chief medical officer for Porter, also Chief Medical Officer at Elizabethtown. a lot of drugs that we use for ulcerative colitis, rheumatoid arthritis, those are actually really high costing medications, and they're in the category of biologic. Some infusion costs thousands of dollars per infusion. So those we do in Porter Infusion Center. So those are probably the medications.
Okay. And is it, to the best of your knowledge, has that been a big shift in the last year?
I am not aware of that, ma'am.
Thank you. And nice to meet you. I don't think we've met yet. Okay, I was also noticing, okay, on page 13 of your narrative, there's a chart breaking down gross patient service revenue by inpatient, outpatient, professional swing over time. And there's an indication of between 24 annualized year to date in April compared to 25 budget, about not quite 2 million, probably more like $1.5 million increase in swing revenue. Could you speak to the assumptions related to swing revenue in your budget compared to actuals or projected actuals?
Yeah, Member Lynch, I'm not quite sure of exactly the numbers you're referencing because I don't have our narrative in front of me, but I can tell you in general that our case management function has undergone a lot of positive transformation, I'll call it, in the last few months, and it's kind of playing into that role that we play for the larger network in patient placement. And we see it in our increased admissions, and we expect to see a similar increase in the number of swing bed patients that we are able to accommodate. So those assumptions are the primary drivers behind that revenue that you're seeing.
And the volume for the swing revenue would be from what locations?
Wherever would be most appropriate. We are a coordinated system, so we take patients from wherever they're able to come.
Within the UVM Health Network or including other hospitals as well?
I assume we're open to all comers, but I will, Dr. Chan.
Yeah, so first of all, serving the community of Middlebury. So we try to get the patients that belong to other hospitals back home. So that would be the priority. But otherwise, whatever the most needs are, but most of our patients come from network hospitals. So to alleviate the stresses of the patient census in Burlington Hospital and also other hospitals that within the network, but serving the community first and also alleviating the needs of our partner hospitals.
Thank you. Okay. Let me shift gears here. So shifting to the fiscal year 23 10% NPR overage. So in terms of it sounds like your justification for the increase over budget is largely due to utilization. Do I have that correct?
Correct.
And could you speak to why, in more detail, that utilization should be recognized in addition to the budget as opposed to some sort of enforcement to correct your budget to the approved level?
I'm sorry, Member Lynch, could you just restate that question?
Sure. So typically we enforce to the approved budget.
Right.
You've indicated your utilization is over. why should there not be some enforcement to the budget due to the utilization in your perspective?
In my perspective, the utilization was necessary. There were, Vermonters seeking care, and, we've been asked to, provide access to care. So we're serving that mission. And as I mentioned in our presentation, there were real costs associated with providing that care. And so to take away the revenue that we received for that at this point would certainly be doing a detriment to us financially. We, as the slide indicated, we managed to make margin for the year, but we did not see a windfall gain by any means.
I think those are my questions. I may have missed one, but I'll pass it on to someone else, and I'll circle back. I'll give a shout out if I find the other questions I might have. Thank you.
Great. You said that MA plans don't pay as well as the rest of the Medicare Advantage. I'm sorry, the MA plans don't pay as well as the rest of the Medicare payers. Is that correct?
As Medicare Advantage plans do not pay as well as Medicare.
Right. That's what I meant to ask. I've been asking so many questions. I might have muffed that, but that's what I was trying to get to. Is that for all Medicare Advantage plans, or are there particular ones that are where that's more of the significant?
It's consistent,
And
I would
just-
say.
Go ahead, Scott, with that answer. Chair Foster, I am just want to counsel anybody, and I don't think you intended to ask questions that would identify what particular Medicare Advantage payers pay to the hospital, because if we want to talk about that, we will need to move into executive session.
I would say
That's
it's
right.
consistent, but it varies across the MA plans.
Okay. And this might be a health network question. There was a line item somewhere on the medical center or health network about a settlement payment from MVP to, I think it was the network or the medical center. Could anyone tell me what that was for?
Yeah, I think we'll have to get back to you, Chair Foster, unless Kelly, I don't know if you recall what that settlement was for.
Would need the reference. We can get back to you. I don't recall that. So happy to get back to you if you could support the reference. We can look into that for sure.
Yeah, it came up, I think, on Wednesday. But yeah, so we'll ask it up and follow up. Does the network receive any remuneration from MVP in connection with its Medicare Advantage plan?
Can't answer that.
I would defer to my network colleagues for that.
Yeah, so the reference that you saw in the UVM Medical Center presentation, Chair Foster, was actually, it wasn't the UVM Health Network. It was the settlement that came into the University of Vermont Medical Center and then was distributed out to the partner organizations. So the health network itself doesn't receive any remuneration because it doesn't bill. It's not a billing entity.
Okay, so there's the UVM MVP Medicare Advantage plan. Any health network hospitals or the health network receive any remuneration in connection with that Medicare Advantage plan?
So I'll look for some guidance. I think we might be entering into the area where we need to provide that in executive session, but defer to Eric if we're now into that space.
I think we do, and it's a question that we're happy to answer, Chair Foster. It might be easiest at this point to pose the question in writing, and we can provide the answer along with a request that it be treated as exempt from disclosure under the Public Records Act, because I also suspect that the folks best positioned to answer it aren't on this call right now.
Okay. Yeah, we can deal with it later, I think. All right, going to Kristen, do you have my I did make some slides. Do you have my slides, Kristen? You can go to the oops. Okay, I might have just left the header by mistake. Go to the next slide. Yeah, I'm sorry, I didn't correct the header. So this is relating to fiscal year 23 and was in the submission you provided us relating to that on the overage from the budget. And I just wanted to work through a couple of these to make sure my understanding is correct. Pharmacy budget, does that earlier with member lunch?
Sorry,
I'm
I don't know
sorry,
if
Chair
you,
Foster, you cut out.
I'm gonna go off camera. We might help with so I apologize. We don't have an office still, so sometimes it's a little dodgy out here. The pharmacy line, the $1.8 million over budget for fiscal year 23, does that include hospital administered?
Yes.
That was the amount of NPR that came in from those hospital administered drugs, not just the cost. Am I understanding that correctly?
I believe this chart is the NPR variance amount. If that's the case, I would say yes, but I don't have that chart in front of me specifically.
it is the NPR variance. Yep.
Letter in response to I think it was my letter about the overage.
Okay.
Okay. So the question, and I recognize maybe you don't have it handy, but for the pharmacy overage, I would like to know how much of that was relating to markup above the cost of the drugs.
Okay.
And we'll do that in follow-up because I'm going to guess you don't have it handy.
That's correct.
And then there's just some of these categories that I wasn't familiar with. Facility providers, is that can you explain what that line is and why it was down by 1.7-ish?
I don't have the breakdown handy of what constitutes that category. I would need to follow that up with that detail.
Okay. Mr. Vincent, do you know by chance?
Sorry, I do not.
Okay. Practices over by 2.3 million. What's included under practice? Can you explain why it was over?
Those represent our physician practices, both primary care and specialty.
And professional revenue?
The physician component of those practices.
Having internet connection.
Chair Foster, I don't know if you can hear us or not, but we can't hear you at this point.
Can you hear me now, Sonny?
Yeah, still a little shaky, but I got Got you there. Thank you. Well, I believe he's trying to get on again, so maybe it'll be better.
I think so. Yep.
Well, and maybe I did miss a couple of questions. So maybe while Owen is working on his connectivity, we can jump back to me just to keep things moving, understanding everybody, I'm sure, would love to have an afternoon. So in going back to the fiscal year 23 enforcement questions. So in your response to Chair Foster's letter, it looked like you were indicating NPR is up, expenses up, margin was up a little bit, but cash was down. Could you explain what's going on with that dynamic with cash?
Yeah, it's really a timing thing. You know, the expenses that you incur need to be paid then, and a lot of those services that you're billing for take time to collect. So your front, you know, those expenses are hitting, you're kind of eating into your cash. We saw AR, you know, kind of rise correspondingly, and then as you get into collections, that cash starts to return. So it was a rush on cash to keep up with the utilization rush.
I see. Thank you. That's very helpful. And I did have a follow-up question about the Medicare Advantage plan. So we have heard from other critical access hospitals that they did receive the same prices from MA, that MA accepted their Medicare prices. So I was a little bit, I wanted to understand more deeply your response about the MA revenue.
Yeah, they accept the rate letters that we get from Medicare and, you know, implement them, but then there are tactics to slow or delay or not pay.
Yeah.
And, you know, these are practices that we not exclusive to MA plans.
Sure.
But, you know, prior authorization, policy changes, you know, rules that conditions that get put in place, things like that, start to cut into that rate that you would expect to be paid.
Got it. And then the other follow-up related to that is, of course, for critical access hospitals, you're able to do some cost settlements, which is favorable for traditional Medicare. Those cost settlements then don't get, the price would eventually get passed on to the MA plans, but they're not really included in the cost settlements, are they?
No.
Okay, thanks. That's what I thought, but like to check my assumptions to make sure that I'm tracking.
Yep.
I'm gonna just pause to see if Chair Foster is back.
A member line.
Hey, Rob.
There he is. He called in.
Yeah, I'm sorry about that. Can you hear me now? Okay.
Yes.
All right. Did you want me to go back member lunch, or did you have more?
Nope, those were my follow-ups. Thanks. I just thought I'd jump in while you were reconnecting.
I appreciate it. Sorry about that to the UVM. Sorry about that to the Porter folks. We're still working without an office, and apparently my internet connection is having an issue today. So my question was on the slide with about the practices and the overage by 2.3. Did you have information on what's in that category?
You're muted,
Scott.
Scott.
You're muted.
Sorry, thank you. Yes, Chair Foster, those are related to our physician practices, both primary care and specialty. And the line below the practices, the professional revenue is the professional component of the practice revenue. As a critical access hospital, we are able to do what is called option 2 billing, where similar to provider-based billing, we can take some of our clinical bills, bill them out of the hospital, and also allows us to include some of those costs on our hospital cost report. So that is why we see two revenue lines associated with our clinical billings.
I see. Thank you. That's helpful. And do you have a month-by-month breakdown for each of these overages?
I'm sure we do.
We'll ask for that in follow-up.
Okay.
And then the next slide. On the outpatient overage of $10.3 million, do you have a breakdown of how much of that was Medicare, Medicaid, and commercial payers?
I do not have that readily available, but I would certainly think that we could provide that. So I would need to in follow-up.
Okay. And then on the bottom chart, bad debt and free care, it says 2.6 million. Am I understanding that correctly, that the Porter Medical Center experienced $2.6 million less in bad debt and free care?
Right, that's correct.
And do you recall how much was budgeted for each of those two items?
I do not, but could follow up.
Historically, has Porter had favorable variance on bad debt and free care from budget?
My tenure with the organization only goes back to 2022. And, I can say with the conversion to Epic and that as a revenue cycle system, it really reset a lot of the accounting of how not only bad debt and free care, but a lot of the revenue cycle transactions were done. So I don't think we have a long historical trend there as an organization that's meaningful. Saying that as I only have been there, 3 years myself.
Okay. And Kristen, I think you can skip the next slide and then go to the one after that. It should say Porter Bridges, and it's for the expenses. On the contract staffing, $8.6 million over on, sorry, $8.3 million over on expenses. Could you give us that in a month-by-month breakdown of when those contract staffing overages were experienced?
Yes, we can.
And going down to the other category, $2 million. Do you know what the primary drivers are of the $2 million overage on expenses for other?
I do not off the top of my head, but we could certainly provide that detail and monthly.
Okay. And then on your slide 6, on the Porter presentation slide 6, you had a breakdown of patient volume driven variance from budget to actual. Have you correlated the overages on expenses to these overages on volume?
Yes. I mean, we can almost directly attribute we can directly attribute, for example, traveler expense, over budget traveler expense to our inpatient unit where we saw admissions be 26% over budget. So to that extent, we can associate the two. Similarly as we can associate, pharmaceutical costs to associated revenue, but the traveler line, the contract staffing line that you were referencing earlier, was a direct response to that admissions volume. And so to that extent, we can track where the travelers are working.
Okay, that would be great. If you could send us the breakdown of where the travelers are working, that would be very helpful.
Okay.
And then I think I'm sorry, did I interrupt? Were there any enhanced or increased increased reimbursements in fiscal year 23 for Porter Medical Center?
Enhanced reimbursements, I would say no. In FY23, we had, corrections to our appropriate Medicare cost reimbursement rate. But that's just normal course of business. I do believe in 23, we had residual one-time funds, COVID-related one-time funds, but again, not rate related.
And we can put it in our follow-up letter, but I'd like to know when those materialized and when they were either applied for or you received notice of the potential of those.
Of the one-time funds.
Yeah, yep.
Okay.
And then I think my last question, did you send a notice to the board when Porter was running above its projected, when Porter's projections were running above budget? Did you send a notice to the care board?
I don't believe we did.
Why not?
I personally wasn't aware that that was a requirement.
Requirement or not, why wouldn't you want to advise the regulator that you are projecting to go above budget?
We submit our results to the Green Mountain Care Board quarterly. So personally, I was assuming that how we were operating was in full transparency. It didn't occur to me for a separate reporting.
Okay. And Porter didn't ask for an adjustment to its rate, its commercial rate, so that would be in compliance with its budget order, correct?
Could you restate that question? Sorry, Chair Foster.
Yes. So Porter did not request an adjustment down to its commercial rate such that it would be in compliance with its budget order, correct?
No, we did not.
Why not?
Again, we were incurring costs that were in some cases more than offsetting that additional net revenue. And yeah, I other than that reason, I don't have one.
Yeah, I'm sorry, Chair Foster. I just want to understand the question. So you're saying that as the revenue was increasing over NPR, but our expenses were even greater, so we were not hitting budget. Are you suggesting we should have asked for, at that point, when we noticed that, asked for an increase in the commercial rate at that point to make up for it?
I was asking, my question was, I'm going to have to paraphrase my question from my memory, but my question was, as Porter was running and projecting above its NPR cap from its budget, why it did not seek a downward adjustment to its rate on commercial so that it would be in compliance with its budget order.
I'm just going to speculate that that would make us further lower on our budget margin, right? I mean, am I right, Scott? That would make our budget even worse our variance on budget even worse. And
right, we incurred offsetting costs in the provision of that care that were equal to the rate difference, and we saw that in the organization basically landing on its budgeted margin for the year.
Okay. Thank you. I appreciate your time and your responses today, and I'll turn it to the other board members.
Go ahead, Tom, if you have questions. I'll go after you.
Great. Thank you, Jess. I only have one. I'm trying to understand the variance in utilization and the resulting impact on operating expenses. What proportion of operating expenses would you consider fixed?
In my opinion, I would consider the vast majority of our expenses fixed. 2/3 of our expense base are our people. And, and we staff to a capacity and we staff to meet patient needs, and those costs are sunk, and so they're fixed. A lot of our, equipment and expense facilities costs are fixed. The variations that we see are things like med surg supplies, pharmaceutical drugs, patient consumables. But that's a small percentage of our overall expense base.
Okay, so
I would just add to that in terms of staffing, so as volumes go up, as Scott highlighted, as admissions went up and other volumes go up, there is a variable component to the staffing that we need to incur as well.
to the best estimate, the fixed cost appear to be 65 to 70% of operating expenses. That's the estimate. Is that correct?
Yeah, roughly 2/3 is what I've seen in my experience. Yes.
All right, thank you. That's all.
Okay, well, today I'm going last, so I just have a few questions. Oh, sorry, was there somebody else there?
No, I was just turning to you. Please go.
Okay, great. No, I just, a couple quick questions. Again, I'm going to ask a little bit about productivity, but in a different way today for Porter. I'm seeing a lot of great new initiatives to increase access to primary care, refer back, self-scheduling, first pass. I think I would have expected an increase in clinical productivity in the primary care practices. And so I'm just curious if I'm missing something, but on page 32 of the narrative, it suggested that for fiscal year 25, Porter PCPs are budgeted to generate 3,723 work RVUs per clinical FTE, which is the 14th percentile. And APPs are budgeted to 3,000 and change, 31st percentile. But then when I looked at the clinical productivity, and we can pull that up if you like, for the primary care practices, they're already above that for the most part. So I just wondered if you could explain that to me. If we can actually scroll down a little bit, we can pull up the clinical, keep going. Yeah. So if you scroll down a little bit and maybe shrink it. Maybe scroll down a little bit more. Yeah, towards the bottom there, I'm seeing already, clinical per FTE, work RVUs per FTE, 4,000, 4,500, over 4,000. So I'm just curious why you would budget for less than a fair number of them are currently generating before these new features.
So Brad, did you want to jump in here on this one?
Yeah, I just want to point out, and tell me if I'm wrong, Member Holmes, we're talking about different years. So the data in front of us is the FY23 actuals.
Right.
It doesn't change your point, but we are looking at different years of data comparing between the two.
Okay, no, I guess what I'm saying is these are actuals. So this is the current or recent experience. And so I was just curious, I'm trying to understand why the budget for next year would be lower than the current experience with the new provider, new provider or primary care initiatives coming on play. Does that make sense? Does my question make sense? Sorry if I'm not being clear.
Yeah, no,
It looks like you're already at these levels, so I'm wondering why you're budgeting for less than it looks like you currently have clinicians operating at.
Yeah, I'd have to take that and follow up to look at exactly to your point, kind of quarter over quarter to graph out the line between that data point and that time and what was submitted in the budget.
Okay, that's fine. And just another quick follow-up would be helpful. I noticed that the wait times have different practices than you have in the clinical productivity table here. For example, I see urology, ENT, and podiatry in wait times. I don't see any clinical productivity numbers there. So I think it would just be helpful, to make sure that we have a complete set of data here. And actually for all 3 hospitals, that would be helpful, just to make sure that we have the complete record on that so that we can track over time. Would be really helpful. So I think you're doing a lot of initiatives that will help on those measures, and it would be nice to see the progress over time. So
Yeah, totally fair if something dropped off. Absolutely.
yeah, thank you. Things happen. I appreciate that. My next question is just, and maybe Kristen, you can pull this up because these are numbers and it might be helpful. I'm finding it's helpful to have the graphs in front or the tables in front of us. This is in the Porter responses to question 19 from the pre-hearing questions. And just to give you as she's pulling this up, this is about Helen Porter and some of the data that you provided on the average cost per day and the reimbursements per day over time for actuals, projected, and budgeted. Follow-up questions. Yep, you got it. Sorry, slight delay here. Yes, great. And it's quite, there you go. Perfect. So I was really, when I saw this, I was really struck by the decline in reimbursement per day from both Medicare and commercial between 23 actual and 24 projected. So Medicare was reimbursing at about $600 a day. Projected is down to $440. But even more profoundly different is the commercial reimbursement was $628 and now it's $205. And I just wondered if you could talk a little bit about that.
Yeah, sorry, Member Holmes. I unfortunately can't. We got this data from Helen Porter leadership, and I cannot explain that decrease. I would note it's a very small percentage of their population, but yeah, that's a steep decline that I can't explain here.
Okay.
I can take a
Follow-up
shot
would be
at
great.
that. I can take a shot at that, Member Holmes, if you
Sure.
allow me to speculate just based on general knowledge.
Yeah.
Everyone cringes when I do this, but it's what happens with the commercial rate or with other ones is that if you stay there you pick your commercial payer, they give you so many days to stay. And then if you don't move out after that amount of days, you just don't get reimbursed, or you get reimbursed at a very low rate. And so I'm going to make it up. If it was 30 days and you stayed at 45 because we just had there was no place else to go, home health wasn't working, whatever it was, the other needs. So the average sort of blended rate that you've gotten, that you collect, winds up looking like that if you don't have any place else to go. So it's a general speculation. And as Scott said, it's for that population there, it's a very small percentage, but that's what happens, unfortunately. And that also applies to the other ones too, but at less so of a dramatic impact.
Okay. So this actually speaks to some of those challenges you all face, all the hospitals are facing, inpatient trying to get to subacutes, and now in the nursing homes, we can't discharge those patients either to home health or other areas. There's just a crazy backlog, right? That's costing the system
That's right.
tremendous dollars. So some of those dollars, this is about $7 million that projected for 24, 5 million projected for 25, and that's with the extraordinary financial relief, right? That's budgeted for, looks like from the footnote, budgeted for 24 and 25 in there.
Correct.
Yeah, and that's hopeful, right? We're hoping that that extraordinary relief comes in 25. It doesn't appear like it's enough. I mean, it doesn't appear like this is enough. So what efforts can be undertaken? And I know I'm asking, Porter Hospital folks this now, and it's a separate entity, but the reality is that this $5 million moves out of the operating margin of Porter Hospital to cover the losses at Helen Porter. So trying to understand what's happening in that facility is important because it affects the rate and the margin. So
it's a general problem though, Member Holmes, right? So let's say Porter didn't exist there. And I'm sorry, Helen Porter didn't exist, and those patients were sitting in Porter Hospital with no place to go. they would get $0 for that period of time, and they would get a
Right.
higher level of care at a higher cost. And so that's the challenge. So we've got the space, so we want to use that. It both allows access for patients that need the hospital to move them, but you're right, you just lose money in one place or the other. And when you look at the work that Oliver Wyman did, I mean, it's that we need these beds somewhere that that the hospital is unfortunately footing the bill for and getting held accountable for. And this is happening at all of our hospitals, because there is no place to go. And so the consequence of it is that we're paying for it, whether it's here or UVMMC, we're paying for it.
Yeah, I mean, I think what we're learning and we're seeing is that it's the commercial ratepayers that are paying for it. And I wonder what sorts of broader efforts, lobbying efforts, understanding efforts can be made with the legislature, particularly coming on the tails of the Oliver Wyman report and the demographic shifts and the need for more long-term beds, to quantify the dollar value that is being, basically imposed on commercial payers to pay for all of this throughout the system. It is tremendous. And this is just another indicator of that. Just a final question, and I don't know that you would have the answer to this, but there are nursing homes that operate in the state at that are not connected to a hospital. And I recognize that some of them are going out of business and closing, so there's a financial struggle there. But are there differences in how they operate, the patient mix, the payer mix, that can explain how those are able to make a margin consistently, the ones that are open, that we can learn from or understand?
My understanding is that and please speak up if someone else, but the nursing homes that are successful are very selective about the patients they take. And so when we try to transfer patients, the first thing you ask for is who's the payer. And if you've had the experience of it, when your time's up, you're moving out. And so they're much more rigid about that. They don't have the same, I would say, I don't want to generalize, but the same commitment to the community. They're the ones that are out there making money. So it is a challenging, and I'm not blaming them. They can't otherwise sustain themselves either, right? Because the reimbursement otherwise doesn't pay for their costs. They can't find nurses, they can't find providers. So that it is a really big challenge. If we could solve this problem across the state, it would go very far to solving, at least for our network, a significant part of our budget.
Yeah. Well, I guess I'll close with just saying, I hope that we can continue that conversation. And I hope that some of the Act 167 work that's coming out and some of the, Dr. Hammery recommendations around system change will allow us to have these conversations more quickly. And if it's possible to quantify the costs of not doing anything about it, would be really helpful to move some change, perhaps. That's all I had. Thank you so much. I'll shift it back to Chair Foster.
I just want to take advantage of that opportunity to echo what I started with maybe yesterday morning, is that, and Steve Leffler echoed, is the only way we're going to solve these is by working together collaboratively with our legislators, our regulators, AHS, the hospitals, to understand these issues and then come together with everyone's perspective to collectively solve it. We will not do it by sort of in an adversarial way of going back and forth, because we won't get to the solution that's going to be best, and it hurts Vermonters. So anything we can do to come together, as you know, I'm a huge advocate for that and would work with everyone willingly to do that. Our entire organization is willing to do that.
One question that Dr. Eppen, I think you're just speaking in the moment, but you said it'd solve a huge amount of the budget problems for UVM. If you have quantified that or have thoughts about what that level of budget woe that would be removed if we solved this issue, send it in to us, because I think that is probably accurate, and it would be really helpful to see how you quantified it.
Great.
And
I think
I don't
if,
think
I
there's
think
any other
if something
board.
like, I think you're asking for, if we have an average of 80 patients that could move out of the hospital and would have a place to go where we wouldn't have to continue to pay, continue to pay the expenses and not collect on. I'm just defining the problem for our team here. And then we can move those patients out and they would be replaced by other patients who need our services at an average reimbursement. What would that consequence be, financial consequence be? I think is what you're asking for. I'm just going to phrase that so that we capture that. Does that sound right?
Yeah.
Chair Foster? Yeah.
We can get back to this. I, on the spot, my team, I might have it wrong, so we can talk about that offline. Okay, thank you. I'd like to turn to the healthcare advocate.
Good afternoon. No questions from us. Really all of our questions are asked by the board, but I did want to just put a note of thanks to Kristen at the board and also our court reporters for all their work during the hearings, because it's a lot. I just want to express an appreciation for all of you, and thanks to the Porter team.
Thank you. Is there any public comment via the raise the hand function? Okay, seeing none, thank you to the Porter team and the Health Network folks for today's presentations. Very helpful. And I'll echo Sam's comments with a huge amount of gratitude to Maggie and Kristen, all of the hospitals, VAS, and the Care Board staff. The Care Board staff works tirelessly, immense hours during the summer when their kids are home and their families are home and it's nice out. And really appreciate the dedication of the staff. And I'll thank the other board members for their hard work as well. So thank you, everybody. It was a good hospital budget hearing session, and there's obviously going to be, speaking of collaboration, we have to make hard decisions. And I hope everyone recognizes that we are trying to make the best decisions that we think are appropriate for the system. And collaboration will sometimes mean things don't go the way people want, and sometimes they will. And when I say people, I sometimes mean payers, I mean insurance companies, I mean hospitals, I mean non-hospitals. Every decision we make has impact across the entirety of the system. And I really appreciate and respect the hospitals recognizing that that is what we are trying to do. And sometimes that means no, and sometimes it means yes, but that is the challenge we are faced with in a really difficult time for healthcare in Vermont. So these presentations were extremely informative and will help us do that duty as well as we can for the state. Is there any old or new business for the board? I will move that we adjourn.
Second.
All in favor, say aye.
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 Aye. We are adjourned. Everyone have a very nice day. Thank you.
Thank you.
Thank you.